Hi, everybody. I'm Evan Smith, the CEO of the Texas Tribune. I want to welcome you to today's event. It's called Running Low on Options, Healthcare in Rural Texas. I know I don't need to tell anybody in this room or the couple hundred people watching us online today that rural health is an important subject, one of the most pressing public policy challenges in a state full of them. And it's not new. There was a crisis in rural healthcare before the pandemic, with more provider closures in rural communities in Texas than in any other state over the previous decade. And the last 2 years didn't make things better. How exactly the public health emergency made things worse and what the future looks like is what we're going to discuss. Thanks so much for joining us. You should know that this is one of the Tribune's first events outside of Austin since late February 2020. We're so happy to be back on the road. We've always believed in the power of convening folks like you for a discussion like this one. It's perfectly aligned with our public service mission, now 13 years old, which is to raise the level of civic engagement in Texas and to civilize the conversation around issues and ideas. These are challenging times. Policy debates and political fights are highly charged and more polarized than ever. I know I don't need to tell you that. But this state we love is better when we come together to talk openly and seriously about things that affect all of us. We're very happy to have you be part of our reboot of live journalism. Before we begin, I want to thank again our generous hosts at Temple College, the president in particular, for welcoming us back onto this great campus. We've been here before, and hopefully we'll be back again. Please give the president and everybody at Temple College a big hand. They made it possible for us to be here. I also want to thank the sponsors of today's event. They make our journalism possible year-round, and in particular, supporting us today makes this event possible. Methodist Healthcare Ministries of South Texas, Texas Tech University Health Sciences Center, the Texas Association of Counties, the Texas Organization of Rural and Community Hospitals, the Texas Rural Health Association, and the Texas Hospital Association. Also want to thank our media partner, the Temple Daily Telegram. Please give our sponsors a hand as well. Acknowledge their generous support. So here's the drill. Our guests and I are going to talk for about 40 minutes. Then we'll open up the floor for questions from all of you. I know you'll have even better and more interesting things to ask than I will. That's how it always goes. I'll make sure to work in some of the pre-submitted questions from the many people watching at home as well. And we'll wrap at the 1 hour mark. Okay? So now I'm pleased to introduce our distinguished guests. On my left immediately is Dr. Sam Hogue, Interim Department Head of Primary Care and Population Health at the Texas A&M College of Medicine, where he's actively involved in a school initiative to improve care and access for the state's remote populations. For 2 decades, he's practiced as a family medicine physician in a rural setting, first in Beeville and more recently in Bryan. Lorenzo Serrano has been CEO of the Winkler County Hospital District in Kermit since 2015. In that capacity, he is CEO and administrator of Winkler County Memorial Hospital. He serves as vice chair of the board of TORCH, the Texas Association of Rural and Community Hospitals, and he chairs the board of the Texas Hospital Association's Rural Hospital Council. Finally, Dr. Diedra Wuenschel is medical director and a doctor of osteopathic medicine at the Coryell Health Medical Clinic in Gatesville, where she also serves as chief of staff. In November 2020, she was appointed by the Coryell County Commissioners Court to a 2-year term as Coryell County Health Authority, the administrator of state and local laws related to public health. Folks, welcome. Thank you very much for being here. I want to start by asking you each to provide some context. Dr. Wuenschel, you first. I want you to tell us a bit about your world, the place you work, the medicine you practice, the community you serve. Tell us what it's like in Gatesville to be in the business, high level, of rural healthcare.
Well, I started in Gatesville 10 years ago because I wanted to practice family medicine full spectrum. I went into healthcare to help families, and it's been a great opportunity. I see patients from birth to death. I see patients in the clinic. I also see patients in the nursing home and in the hospital. I also work at Mills County, which is an even more rural area, about 30 minutes from Gatesville, or 45 minutes from Gatesville. It's been a great opportunity seeing people live their lives, and that's what I wanted to do, was go there to make a difference and show people how we can help them in multiple different ways. And these last 2 years have been even more difficult with that, but I think we've brought a lot of things to the community.
The perception, we'll talk about this a little bit later, is that the population in rural communities is hemorrhaging. It's not exactly right. There's still a lot of people in rural Texas. Your days are full. Despite this idea that somehow nobody lives in rural Texas, the fact is your days are full, right?
Very much so.
Yeah.
Yeah, I had to move patients around just to get here.
I believe it. And thank you for changing your schedule to make time for us. Mr. Serrano, different situation or similar situation where you are?
I'm currently the CEO of Winkler County Memorial Hospital. That's
Right.
in the middle of the oil field patch, far
Right.
west Texas. We're a 19-bed critical access hospital. We have just under 100 employees. We serve a community of a population, or our primary city is about 7,000. The community, or in the county, is about 9,000. We have 5 total providers. It was just to echo, it was a pleasure. I enjoy my job very much so. COVID, not so much. It was definitely hard, much harder than usual, but I enjoyed serving our community. I mean, in that time, COVID has changed completely how healthcare looks, how we respond, how our operations are, and so, it's...
Well, I'm going to want to talk about exactly how COVID has changed it. Every bed is full in your hospital, right? Every bed is full?
During the peaks, for sure.
During the pandemic, every bed was full.
Yes.
For sure. Dr. Hogue, you come at this a little bit differently. Both these folks, Dr. Wuenschel and Mr. Serrano, are associated with hospitals. You're a family doc, right?
Yes.
You're a provider of a different sort. Tell us what it was like for these last couple of years.
Yeah, thank you. Thank you for the Texas Tribune and Temple College. It's a pleasure to be here. My passion is family medicine. I practiced family medicine in a rural area for 20 years. Currently, I'm in academics in Bryan College Station. We have a family medicine residency there that trains full-scope family docs to go out and do cradle to grave with OB, and we send them out to rural areas. So we're sending out 10 young doctors every year to rural America, and I'm glad to be here, glad to talk about rural health, and thanks for this opportunity.
So you are or are not still seeing patients yourself?
I do have a clinic for my private patients. It's
Right.
very small, but most of my oversight is on the family medicine residents.
Right. And the kids who come through, and they're probably not legitimately kids, but for argument's sake, kids. The kids who come through come in knowing that they're going to go out and go into communities that are underserved traditionally by medicine, by healthcare.
Absolutely.
Yeah.
And
are
I still
enthusiastic
call
to
them,
do it.
I still call them kids all the time.
You do? Okay.
Yeah.
And
Try not to slap them on the back.
I'm certain that
kids.
if I will get canceled if I use kids in this context, so I'm going to regret. We're just going to go back and edit this out of the tape. That's actually fine.
Okay.
Right. Mr. Serrano, I'm stuck on what you said about how COVID has changed everything. In some ways, I'm thinking I've already got the headline of this conversation. Not that I didn't know it, but could you be more specific? Put some flesh on that. How has COVID changed? I want you to, in some ways, go back pre-pandemic. I say over and over, things weren't great before the pandemic in rural Texas. They're not great now. I also know that the after is going to be different from the before in all ways, right? Everything has changed. So put some specifics to that. How's it changed?
Oh gosh, unprecedented staffing challenges. I mean, it's always been tough to staff a rural hospital. On top of COVID, you had an increase in the patients. You had fear from the nursing staff, med staff to treat COVID patients. We had to be very creative, very innovative on how we can keep our staff safe. We went from seeing patients outside to drive-through clinics. We had to completely redesign how we handle healthcare. We had to implement very rapidly telehealth and telemedicine. There was not one part of the organization that wasn't impacted. There was a very large increase in burdensome governmental reporting. Almost every day there was a new survey that would pop up in our email, and it was due by the very next day. The CEO, CFO, CNO.
Is that federal, state, local, or all of the above?
Every level, federal, state.
Right. Yeah.
Absolutely.
And there was no playbook, Mr. Serrano, for this, right? I mean, one of the things I think about for somebody in your position or somebody like Dr. Wuenschel who are running big institutions, even in these smaller communities, these are still pretty big institutions, is you had no preparation for this. You were caught off guard, like all of us were caught off guard about what was coming. You didn't have a way to prepare for what was coming.
The standard of care in rural hospitals it's the same. It's the same as your urban markets. It's the quality of care has to be the same. We just have to figure out how to do that with less staff, less resources, less financial resources. It's hard to run a hospital in and of itself. When you add everything that COVID brought,
Right.
It was very difficult.
Tough under good circumstances, and then it gets worse from there. So how long did it take during that 2 years plus for you to feel like you'd reestablished something normal? Or are you still not there?
Only until recently did we finally start seeing things really
Right.
normalize, where we felt we understand what we have to do. We weren't in crisis center, crisis mode. But now, we have to do all the projects that we delayed for 2 years, all the building, everything that we had to do, policy writing, disaster plan, everything that we delayed.
Right. Yeah. Dr. Wuenschel, same. It was tough enough before the pandemic, and then all of a sudden everything blows up.
Yes, definitely. And throughout the clinic, things changed. And throughout those 2 years, at the very beginning, we were changing policies daily. And it's difficult for staff to do that. They're used to black and white. And we were like, okay, we have now changed to this. We're going to do this. And then we would send a new policy out the next day, because being in a rural health community, we were also helping the schools. We were helping the daycares. We were helping everybody navigate this throughout the entire time. And so when as schools started to reopen and masking and all of that, it was our duty to help them keep everyone safe within the school district as well. They were calling me whenever somebody was positive. It wasn't some person in Austin or anything like that. It was me helping them to decide if the daycare needed to close. If the daycare closed, then that meant nurses would be staying home, which meant we had less staffing. So thinking
It's kind of a cascade, right?
It is a cascade, definitely. And at the very beginning of the pandemic, we had nobody wanting to come. Nobody was coming. No one went to the ER. Everyone was scared to go anywhere. And then at the height, we were full. We were full in the hospital. We were full in the ER. We were full in the clinics.
As Mr. Serrano said, beds full, kind of overrun.
Yes.
The story was that there are so many ICUs that are without beds. You were in that situation, right?
Yes, definitely.
Yeah. I'm listening to you talk about this, and I'm remembering those first couple of months of what we didn't know what we didn't know, right? We made a lot of assumptions about what the risks were, and there were legitimate risks. They may not just have been the risks that we solved for at the time, right? It was in some ways repairing the plane while in flight.
Exactly. That's what we kept saying to all the staff.
Yeah. Dr. Hogue, when you think back on that first couple of months of the pandemic, what comes to mind, and how did your own practice of medicine or your own training of future docs and medical professionals change during those 2 years?
Yeah, that's a great question, and you hit it right on the nail. We didn't know what we didn't know. So our program has 50 doctors, 30 in training and support faculty. So we immediately shifted how we did things. We split the hospital coverage week by week with faculty and residents and gave them a week off. So if they had exposure, they would be, in isolation. Yeah. And we tried to maintain a virtual presence. Of course, many clinics were shut down. We were fortunate that the big waves were up north, so we were bracing and getting ready, working with the hospital, getting the negative pressure rooms ready, getting enough masks, making sure we had ventilations, and really the community came together about those critical needs. I had to learn to don and doff, and it really is time-consuming for every COVID patient that you see to have to protect yourself and protect others, and then go to the next room and do that. So it really shook up what we were doing.
And again, no preparation for this. No,
Oh, yeah.
no playbook that you could dust off, because we'd never actually experienced anything like this in our lifetimes.
Absolutely, yes. And a lot of our staff we allowed them to work at home because Dr. Wuenschel is exactly right. You got a child in school that needs to have virtual learning. We need to be flexible and let them work from home and do what they can. So,
were there any positives, Dr. Hogue, as far as that went? I mean, I often think about our business as a microcosm of the world, just focus on the thing you know. So in our case, we were out of our offices from March of 2020 until July of 21, came back for a little while, then went back home, then came back earlier this year. And in some ways, the problem isn't that we couldn't do our jobs from home, it's that we could do our jobs from home. So that now when you try to come back, people are like, well, really, I don't want to come back or don't have to come back because we realize that we can do our jobs. Were you able to do your jobs remotely? I mean, I think of medicine as something that you want people in the room with you, right?
You still need that patient-to-patient, face-to-face contact. But yeah, we did visits, but I did learn a lot of our administrative staff actually needed to stay at home and not come to work and visit with everybody. They were much more productive at home. So,
as I said, the problem is not that it doesn't work. The problem is that it does work, actually, right?
Yeah.
Dr. Wuenschel, Mr. Serrano, same thing. You had people working from home, and it actually was you were able to make it work that way.
Very limited. You know, we had to figure out how to keep the hospital open, and you know, for us, unfortunately, it's just not practical to work from home. We did some virtual meetings, but we needed our staff there. We needed our staff, you know, just running the hospital, day-to-day operations. It just wasn't practical.
And did you have sufficient access to broadband out there? We'll come back to broadband as a factor in all this in a second.
We do facility to facility. We do not have sufficient access from home to facility or home to clinic. We tried to do telehealth in a traditional way. Unfortunately, we quickly learned that it just wasn't going to work, so we switched over just to phone visits and telephone visits.
Old school. Old school. Dr. Wuenschel, did you have people working remotely during this period?
We did, but like he said, there's a lot of difficulty if we're sending a coder who normally would be coding things in the office where we actually had a good internet and they're trying to do it in their rural home that does not have good internet, that's very spotty. That was always a difficult
we know
time.
that a very high percentage, even in 2022, of rural households don't have access to high-speed broadband. We're trying to get on the other side of that, but it takes a while. And anyway, in the middle of a pandemic, we realized what a real emergency it was. Dr. Wuenschel, a narrative developed in 2020 and even into 2021 that in rural communities there was less willingness to accept reality. This is not my narrative, but this is the narrative that was out in the world. The reality of the pandemic existing, there was hesitancy to wear masks, there was hesitancy to get tested, that there was hesitancy to get vaccinated. Is that a fair characterization of the community that you were in? Was the divide between the reality in the big cities as it was perceived and in some of the rural communities as it was perceived really a thing?
I mean, I think we had some outliers, but the majority of our population, they were bringing us gloves, they were bringing us snacks, they were saying, thank you for doing everything that
It was
you're
a similar
doing."
conversation to the ones that might have been in bigger communities.
Yes.
Yeah.
I mean, they wanted us to be safe. We were their family, we were their friends.
Right. Now, I shared with you before we started today that I actually got my first 2 vaccination doses at your facility in Gatesville. Drove from Austin to Gatesville to be vaccinated in 2021. And the reason was that we in Austin heard, well, this is a rural community where there's a higher degree of hesitancy about the vaccines. And so there are more vaccine doses available in those communities. You might be able to get an appointment. Was that a factor in your world during that period of time, that there was some resistance maybe?
There was some resistance, but we knew as a community we needed to become a vaccine hub, and we were going to make it happen. But in order to be a vaccine hub, you had to allow everyone to come. And there were times when we were a little frustrated and we would try to figure out ways to make sure our own community could come get vaccines. Because like I had told you before we started, somebody flew from Chicago and came and got a vaccine in Gatesville, Texas.
And from your perspective, that was all good. Right?
Yeah, I mean, at that point, we had gotten our community vaccinated.
Right.
And we're continuing to do that. We just wanted to make sure that we had the ability to give those vaccines.
Right.
And so we were giving 900 a day if needed.
Yeah. Dr. Hogue, the mood on the ground in Bryan during this period was what? Was there an acceptance of what was going on? Was there a willingness to approach it the same way that people in other communities might have approached it?
Yes, in Bryan, it certainly, there was well awareness. But when I visited my hometown of Beeville, I definitely saw a culture shift. In the height of the pandemic, we'd made some meetings around our rural health pilot program there. And I went into a local restaurant with my mask on, socially distancing, and when I walked in, no one had a mask on, and they all looked at me like I was from outer space. So yeah, there's definitely was a different culture there. Yeah.
And what did you do about that, or what could you have done about that? I mean, this was something that I think a lot of us in the state confronted, where you were almost having two different realities.
Correct.
And it was very hard to persuade people who are on the other reality from you that your reality was the right reality, whichever reality you happen to be in. It's one of the things we dealt with over the last 2 years, right?
Yeah, it's very frustrating as a physician to see that a lot of your patients really don't trust you, and you're supposed to be that wealth of knowledge, and they're listening more to other stakeholders within their community. So you have to recognize that.
Say more about that. Mr. Serrano, I'm going to come to you 1 second. Say more about that. I want to talk about that lack of trust. That's really interesting to me. We have a larger problem of a diminishing amount of trust in institutions, and I'd put medicine in that category, actually, after the last 2 years. You experienced that firsthand.
Sure, and you know, I get it. The CDC was changing their recommendations and backing up, and yeah, so Beeville, Texas had a very robust vaccine effort. They were a hub within a rural hub. They did up to 25 vaccines a day. So people such as yourself that were very highly motivated got the vaccine, but when you look at the underserved community, the African American community, the Latinx community, what we experienced in Bryan was they did not want to go to those public health vaccines. There was a lack of trust. Quite frankly, with the Latinx community, you know, they live, a lot of them within a certain geographic area. They're kind of don't want to stray outside of that. So we had to be innovative and go in, on their ground, talk with their stakeholders, get the encouragement and the buy-in. I remember when we went out to one of the Baptist churches, African American church, had a very interesting conversation with the pastor that there was so much mistrust, and you know he acknowledged, you know, he went up to the county and got his vaccine, and there was a lot of misconception that they were segregating them and doing things to them, talking about the Tuskegee. So I get it. African Americans haven't always been treated fairly, but the reality was the people that we were vaccinating that day, if you ask them, why are you getting a vaccine? The large majority were getting the vaccine because their loved ones died. I can't tell you how distressing it was. Fine. What motivates you?
It took that.
Oh, yeah. Why are you here? Well, my husband died from COVID, so I think maybe I ought to get vaccinated.
Mr. Serrano, this sound familiar to you, this story?
Yes. So initially, when COVID first hit, there was definitely fear. There was definitely the idea that this was fake or planned, and we all heard all the, you know, all the rumors and whatnot. There was a definitely mistrust, you know, in the medical system. But for us, it didn't become a reality until we got our first COVID case. We didn't get our first COVID case in our community until August of 2020. And when we had...
Excuse me 1 second. It took you how long? From March, when the rest of us all were told, this is it, we got a lockdown, August was the first time you got the first case?
Our first positive test.
Wow.
Yeah. But then
well, I guess if you have no positive cases between March and August, you could be forgiven for thinking that there's not actually a pandemic, right?
Absolutely.
The mood changed in August. When we got our first hospitalization, when we had our first death, definitely the community was looking to us then. It was uncommon to get calls from just local businesses, schools. I have a sick staff member. Should I keep them home? Should I not keep them home? I got a doctor's note. You know, almost every day we got a call. I was exposed to this individual. You know, what should I do? And so once that hit, you definitely saw the community just embrace this and kind of rally together.
Did you have sufficient access to the basics in Winkler County, Mr. Serrano? Masks, tests, vaccines? We did some reporting during the pandemic that actually suggested that rural communities were not getting adequate supplies. I wonder if that was actually the case.
We were very fortunate because we didn't have the spike initially. We started stocking up on supplies in January. Once we heard that COVID was happening in China and whatnot, and there's this new virus out there, just because primarily that's where we get a lot of our supplies for, we started stocking up masks, N95s, gowns, anything we thought. And by the time we worked through that backstock, that's when the supply chain started getting interrupted. So we were very fortunate that we didn't have those issues.
You had prepared. Dr. Wuenschel, I know that you had enough vaccine doses because you gave me one, 2. But I wonder about the other stuff, basics, masks, tests, all that sort of stuff. Did you have enough?
We did. As we started learning things that were going on, that's what we were doing, investigating. We were stocking up on supplies. We actually became a testing center at one point as well, where we were doing drive-through testing because we got our own machine and were able to test, and we had other places sending us tests.
Can I ask you, before I bring Dr. Hogue into this part of the conversation, I'm conscious of the fact that in a number of instances, there were restrictions put on non-emergency procedures, elective procedures, non-COVID procedures, and so people actually couldn't go to the hospital to get something that wasn't urgent. How much of an impact did that have on your community? Did you feel that? Did people in the community feel that?
People definitely felt that. I mean, unfortunately, at times, you're ready to get that knee surgery, you're ready to get that back surgery, you're in pain, especially when we're a year in and we're canceling things because, again, every time COVID spiked, then things got canceled.
Back to normal now,
Yep.
as far as that goes,
Yes.
yeah. Dr. Hogue, was there any concern about having access to supplies in Bryan or in Beeville when you visited?
Yeah, there definitely was. Because we have such a learning program, we modified to limit exposure and conserve supplies, so especially our PPE. So yeah, we definitely did that. I don't think we got close with gowns. I know the hospital was conserving their N95s, and so it was close, but we were okay. But it was definitely a problem.
Yeah. Mr. Serrano, inevitably I'm going to ask you about state politics. It took me 25 minutes. I promise you I've done my best to resist, but I'm going to ask now because I've been desperate to ask. We had big fights over mandates over the last 2 years, mask mandates, vaccine mandates, what have you. Not quite as big a fight, kind of because it was over before it started, about Medicaid expansion or about the impact of the stop and start renewal of the 1115 waiver. This is all stuff that people in this room, most people in this room, understand the importance of. Over the last 2 years in your world in Winkler County, did government help or hurt? Did state government help or hurt? Did local government help or hurt?
Initially, they were a big help. We received CARES Act funding. That CARES Act funding, that helped it really helped offset the loss of revenue that we experienced. From 2020 to 2021, we experienced about a $4 million decrease in patient care revenue. Not only that, because what oil did, we actually experienced a 9% decrease in mineral property valuations. And so tax rates have to go up just to get you the same amount of money as previous years. CARES Act supplemented that. But what it did not do is it didn't fix the rural payment inequality. All rural hospitals are paid below cost for Medicare and Medicaid.
The economics have been screwed up for some time. Yeah. Didn't need the pandemic to see that, right?
CARES Act did not do anything to fix that.
Right.
We are still seeing high cost. The last 2 years we've experienced a 17% increase in cost. Those costs are still very real, very with us. The CARES Act funding has run out. Right. And now we're forced to figure out how to survive.
How much in the hole, back in the envelope, are you as a consequence of the last 2 years economically?
To be honest with you, the first 2 years, because of the CARES Act funding, we actually ran a positive margin. This year is when we're really seeing the effects.
In some years, as the pandemic is fading, the trouble is coming.
Absolutely.
Because the money's running out. Now, I can't help but notice that CARES Act money is federal.
Yes.
What did the state do for you to make you whole?
There were a few grants, supply grants, testing grants. We recently received another grant to continue to pay for testing. Very limited in that aspect. We don't have a lot of Medicaid volume. We have a very high uninsured volume. In oil field, there's good paying jobs. But they don't necessarily can provide their employees with insurance. And so very high uninsured population. That continues to be the case before COVID, during COVID, after COVID.
And that was a problem during the pandemic.
Absolutely.
Right. Dr. Wuenschel, did you see government, I mean, you are government in some ways, right? You're the county health authority, so but did you see government as a force for good or as an impediment to trying to solve some of these challenges over the last 2 years?
I think at times it impeded just because, unfortunately, we all can have childlike tendencies where if you're going to tell me to do something, I'm not going to do it. And so I think a lot of times just even talking scientifically, people would understand more, or telling them your individual story. And I think that as a small community, those are the things that helped. But if someone's telling you that you have to do something in order to be there, a lot of times we get resistance with that.
Would you have preferred to have the state allow you to put policies in place that you thought were appropriate to the circumstances you were in, as opposed to telling you that you couldn't do stuff? I always tell people a mandate against mandates is a mandate, right? I mean, so how would you have preferred this had gone?
Yeah, I think with each local community, it would have been easier, just whatever is going on within your community. Because yes, unfortunately, you know, it did hit larger cities first. It was in New York. But and that's one thing, when we were shut down, we also don't live on top of each other. So we have lots of area to play and not be on top of each other.
But you would have preferred to have the flexibility to put whatever policies in place.
Yes,
that
that would have significantly
Mr.
improved.
Serrano, same on that?
Absolutely. I think I wish hospitals would have been able to make the decision themselves, whether you could stop surgeries, elective surgeries. But
Right.
we didn't experience COVID till much later in the surge. And
Yeah.
it wasn't just hospitals. You had barbers, you had bar owners. I mean, they couldn't open up their business, and we didn't even have a COVID case, you know, in the community. And so,
Right. Dr. Hogue, unlike Dr. Wuenschel and Mr. Serrano, you and I are old enough to remember when local control meant that the locals controlled things.
Absolutely.
Right, that old Jeffersonian idea that the best government is closest to those being governed, which now seems to have been inverted. And during the last 2 years, we saw that government from Austin told people in local communities like Gatesville, like Kermit, like Beeville, like Bryan, what they could and could not do. And my question to you is, was that a good thing or a bad thing over the last 2 years?
Well, the problem with mandates are there's consequences that you don't always anticipate. So we immediately saw nursing staff just under the threat of having to be, for instance, vaccinated. They did career changes. The state.
So folks who worked for you being told you must be vaccinated to work in the hospital or in the
Right.
clinic said, I would rather change professions.
Absolutely.
Right.
Yeah. And I'm aware of some that were single parents in the nursing profession for years that just got out of nursing, had an early retirement. So it was devastating.
It works
for them.
both ways.
Yeah. And when I heard about the mandates, I really didn't worry that much about it because we're in Texas, and I knew they would litigate that till the problem was over.
Right. What did the governor say when he was the attorney general, that his job was to get up in the morning, sue the federal government, and go home, right? And that's pretty much how we approached this during the pandemic, right?
Right.
Yeah. You mentioned the idea, Dr. Hogue, of nurses potentially leaving the profession. To all of you, I'd say one of the big things we've heard about the last 2 years and about the state of rural healthcare today is that there is a staffing shortage across the board, maybe nursing first and foremost. Are you feeling that where you are, that there are not enough medical professionals currently to serve the community that the community needs?
Yeah, and I think it's more than just numbers, because when you look at it, if you have a very skilled senior workforce and they're quitting, you're left with a much younger, inexperienced workforce. And even if the numbers are okay, it's different. It's different.
Quality of care is not as good.
The quality of care is okay, but there's nothing like going in the room when everybody's nervous versus you go in the room and a nurse can tell you what's going on. She's putting the patient at ease. She's communicating. That's something that has to be learned. Yeah.
Dr. Wuenschel, do you have a staffing problem in Gatesville right now?
Yeah, we have seen that affect our community significantly. But the other thing that it's affecting is when there's staffing shortages in our tertiary facilities, the places we want to transfer our patients to, they no longer have beds when they have a staffing shortage, which means that we're having to keep patients that we normally wouldn't keep in our rural communities and take care of them when maybe we would have sent them somewhere else where there was a specialist, because everyone is full. And so, yes, during the pandemic, every hospital was full of patients, but sometimes we're considered full because we don't have staffing.
And so if you lost people in Gatesville, were there other people you could call? I mean, was the population, was the pool, the talent pool large enough that you would be able to replace people?
We are have staffing places trying to staff us, but you're paying a lot of money for that.
So the economic concerns get
Yes.
worse.
Yes.
Mr. Serrano, in Winkler County, was this a problem? Staffing shortages?
We had several openings. I think it was tough before COVID. It was definitely tough during COVID. But we experienced the same thing. Our tertiary facilities did not have enough nurses. I think at one point the large facility next to us had over 100 openings for nursing. So we were sending patients all over, Colorado, New Mexico, San Antonio, very far from us, just to get them to a higher level of care. And we were accepting and keeping patients longer that were really needed a higher level of care. And so it was scary. Staff was scared to do that. We had to keep staff calm. Our providers really stepped up and did things that they were normally just stepped out of their comfort zone to do extra to keep patients longer. And
What percentage of your staff right now do you think is, let me say it differently, what percentage of your jobs are filled adequately at this point?
we only have 2 openings right now.
Out of how many on staff?
We have 94 total employees.
Okay, so that's not so bad.
No.
But that's improved during the last 2 years.
Absolutely. If you do have a nurse, at one point in the height of COVID, we had 3 nurses, RNs, with a staff of 16 total RNs, come down with COVID. At the same time, we were experiencing a surge. And so we definitely had to look for agency to fill that gap. It was uncommon to pay $120 to $140, $130 an hour just to get an agency nurse, if you could find them. We took a different approach. We started incentivizing our staff to work doubles. We would pay them the same rate that agency companies would pay, and if they agreed to work a second shift, very expensive model to operate, but we thought we could keep the
Well, at least you'd rather have your folks who know
Absolutely.
the facility, know the community, know the patients, right, all that kind of stuff.
It just doesn't last long.
So telemedicine, in theory, would have been a solution to some of this, but again, Dr. Wuenschel, you said spotty, right? Didn't really make a huge difference.
Right. It was, some really enjoyed it. They would be out on their boat fishing and do their telemedicine, but it was difficult, especially with some of our older patients who were scared to come in. And so you were doing a phone call with them, trying, there's things you can see just looking at somebody's face. And when we couldn't get it to work, or it would shut off, or you would stop mid-sentence.
Well, the idea that some people may not be comfortable with technology even if they have access to broadband,
Yes.
and then a lot of people don't have access to broadband, and so that's it. Same, Mr. Serrano?
Absolutely.
And same, Dr. Hogue?
Yes, I'd never done a Zoom meeting, didn't want to do a Zoom meeting, but I rapidly got to where I liked it. I liked the fact that I didn't have to travel.
You able to treat people that way?
To some extent, our problem was on the receiving end. The patients always didn't have the true telemedicine, which requires audio and visual. So they were mostly phone calls, and it definitely lacking.
So we're going to go to questions from the people in the room, and I've got a couple of questions from folks online in a minute or two, but I want to ask kind of a high-level existential question of the three of you, and that is the problem with fixing rural health care that we don't know how to do it? Or is the problem that we do know how to do it, but the mountain is too steep to climb? In other words, I'm thinking about the population of rural Texas right now, which is 3 million people. It's only about 10% of the total population of Texas. It's the smallest percentage of the total population that it's ever been, and it will never be this high again because most of the growth in the population over the next 30 years is going to be in the metros, not in rural communities. But 3 million people is a lot. Like, this is not a small hill to climb. It's a mountain. So, Dr. Wuenschel, do we know what it will take, or do we not know what it'll take? Like, if I said to you, you could fix it, go fix it. Could you fix it?
I think it would just take a lot of work. Part of it is just and we saw that during the pandemic. Our local rural health communities came together to help each other, like I said, with the testing, with the vaccines, with all of that. We actually would just be calling each other, okay, what are you doing for this patient?
Yeah, but that's like a patchwork of fixing it as opposed to a strategy, intentional strategy. Is it money Is it people? Is it time? Is it all of the above? Like, what would it take if you could just wave a wand over?
A lot. All of the above.
I think rural hospitals actually showed what we can do in COVID. I mean, we were innovative. We had pressures, but we rose to the occasion. It's strictly financial.
So it's money, like a lot
it's
of
money.
other things. It is money in the end.
Absolutely.
So would you be advocating to the next legislature that they put more money into healthcare? Would you be advocating that they finally bite the bullet and expand Medicaid or access some of our tax dollars that are going to other states to pay for healthcare there, since we're not taking them back? What would you say to your legislators?
Just look at the facts. I mean, since 2010, how many rural hospitals have closed?
More than 20.
During COVID, for 2 years, for the first 2 years since 2010 or 2011, no rural hospital closed. Why? We got CARES Act funding. Again, that funding's gone. The broken finance system for healthcare facilities, it's still a reality for us. It's a reality in a time when it costs more expensive than ever before to run a hospital.
So even the renewal of the 1115 waiver, which again was a political football for a little bit, now it seems like that football is sort of off the field. That's not going to solve the problem for you.
All that does is it helps subsidize a small portion of your uninsured population. That's existing funding. That does nothing to relieve the increase in cost. Like I mentioned earlier, our property values decreased. So we have tough decisions to make. Do we want to raise property taxes more and further burden our local, our local taxpayers? Or do we stay flat, give them a break, but then what are you going to do for inflation? And so those are very tough decisions. We definitely need some relief, legislative relief, both federally and at the state level.
Dr. Ho, do you agree that the legislature needs to spend more money on healthcare? Is that the answer?
That's part of the answer. I think from my perspective, what we're not doing is engaging communities more directly. If you've seen one rural community, you've seen one rural community. Their needs are very different. There are some commonalities. Access is always one. Right. Some have more opportunity. But yeah, we need to do more ground level up. And yes, we're at A&M under the umbrella of the rural health, under the umbrella of the health science system, the College of Dentistry, Medicine, Pharmacy, and Public Health. We're going to ask the legislature to let us showcase our model and see how we can do a grounds-up approach. It's about education. We're not educating and encouraging our rural students to go into health fields. We need to do confidence building for them. Yep. I think that's very important.
All right, so let's take some questions. My colleague Jackie Brinker will walk the microphone around, and if people have questions, put your hand up. We'll bring a microphone to you, or you can come up to it. And to begin, though, I'm going to ask a question of all of you from somebody who wrote in. And so David submitted a question, and actually I'm going to ask Dr. Hogue this of you, since you're the one who probably has the most expertise in this. Does Texas have enough family practice residency slots to accommodate applicants in Texas?
That's a question that really gets me excited. The answer is definitely no. The Robert Graham Center says we need 6,000 more primary care doctors by 2032. We are opening up medical schools in Texas, but we're not offering that postgraduate residencies. It's very frightening to me. When I graduated medical school, everybody got a residency spot. The trend now is 78% of those medical school graduates don't have a residency to go through. Can you imagine?
So
4 years of medical school and
as a practical matter, that is something that the legislature could have an impact on, right?
Absolutely, and there are some programs that are getting some traction. There is a 1+2 program where you can do a family medicine residency at a more urban area in the last 2 years in the more rural, and with the intention maybe you'd stay there.
Got it. Okay. Anybody in the room? Please come on up. President, go ahead. Yes.
My question was a little similar. Thank you all so much again for serving on the panel. With the closure of so many rural hospitals, the impact that we saw was less spaces for individuals to get their clinical training. And so do you have any strategies on how to increase the number of clinical spots when you have so many closures?
Dr. Wuenschel, do you have a thought about that from your side of this?
I mean, the biggest thing is just getting experience in multiple different places and being able to do that. Within our own nursing home, we have started our own CNA program because we found that we could utilize them during the pandemic. We got the ability to use them as CNAs and, getting the on-the-job experience, and that's probably the biggest thing.
Dr. Hogue, same?
Yes, so we look for opportunities where we can tie education to recruiting. So in those rural areas, are we really reaching out? Do we have nursing students in all those spots? Do we have medical residents and medical students in all those spots where they can be trained and educated and recruited by those communities? So yes, there's opportunity. We just need to do a better
Is there
job.
is there a possibility in the legislature to create incentives for people to train and remain in rural communities? Loan forgiveness, some other sort of stuff.
There is
right?
loan forgiveness. The state has a very good loan forgiveness, but you need to stay in the area for 4 years. Unfortunately, my experience has shown that if you recruit a doctor, you pay their bills, you give them a lot of money, but you don't make them part of the community, 4 years goes by and they're out.
The first day after 4 years.
Yeah, so you really need to get with that community and have them really engage the provider, really get them as a part of the community for sustainability. We had a J1 waiver for foreign medical graduates. It was a good idea, but the way I saw it is in Beeville, we had very good specialists. We had a nephrologist or a kidney doctor. We had a critical care doctor. They did tremendous work for us. But when they left, Dr. Hogue didn't manage the vent in the hospital anymore. So it actually degraded our level of care because they went on and practiced in the big city, which was fine. They were an asset. But when they left, it was a big void. And without being actively involved in that day-to-day experience, you lose your skills.
Okay.
So,
Mr. Henderson.
Two questions, if you don't mind. Sure. First one's for all of them. We talked about workforce issues and recruiting clinicians to rural Texas. And we talked about broadband, but what we didn't talk about was housing. We talked about low cost of living, but people remind me that that's only if there's property available.
Right.
In Beeville and Kermit and Coryell, are there houses on the market, or is that a challenge?
It's a major challenge. We actually, for the last 3 years, every single year, we've had to go out and buy properties just to house
Right.
our staff.
Well, I remember actually when the oil boom, 2 or 3 versions of the boom ago, and there was talk about apartments going for rates in Midland that were bigger, more expensive than in the big cities. There were man camps being put up right in the Permian to accommodate all the people working in the office. You've had a problem in housing for some time, right?
Prior to COVID, during COVID, continues to be the case.
Continues to be an issue, right? So how about in Gatesville?
I would say the same thing. Even 10 years ago, whenever I was moving to Gatesville, there's not apartment complexes. There wasn't really a place. And coming out as a resident and then trying to purchase a house, that was a difficult thing. Luckily, I was able to rent the house that I was buying so that I could show that I had been there for a month prior to purchasing the house. But it's always been a difficult time. And like I said, I moved there 10 years ago and had the same problem.
When trying to recruit physicians, that's the hardest sell, housing.
Right. Well,
What
so
am I gonna
Dr. Hogue, I'm going to add on top of what Mr. Henderson said, because we could talk about the whole suite of things available to people in rural communities that would either attract or repel people at job time. You have 700,000 kids enrolled in rural public schools. 60% of rural public schools don't have AP credit or classes. Like the question of investment in rural public schools becomes another conversation. Well, do I want to actually raise a family in this community if I feel like the public education system is not bent in the direction of providing my kids with opportunity? Like, this is all a bucket of things, isn't it?
yeah, correct. And these rural communities, they need to be self-reflective and put themselves from that professional or health professional's perspective. What's going to keep them there? What's going to make them feel safe? What value is it to join as part of that community? So yeah,
You have to offer more than a job. That's the
right. And yeah, you need to really engage
Right.
that provider.
Yeah, Mr. Henderson, question
So the
two.
second question I might aim at you, Dr. Wuenschel. Lorenzo said that rural hospitals stepped up, and when we were most proud of them was when the state, every region of the state was struggling with bed capacity, and rural hospitals were actually taking patients out of the city to free up beds. I know Gatesville was a great example of stretching when you couldn't get a patient into Temple or Waco and doing ICU level care and vent care. The question is, do you think that's something that you gain confidence in that you might hold on to, or are we going to go back to the 2019 model of stabilizing ship?
No, I think we gained confidence in our ICU beds, and also with our nursing staff, knowing that they can do it, and that, I mean, we had a patient that actually transferred from a small hospital to us, and we were able to get them off the ventilator, and it's a great story within our community, and so it helped build confidence and helped.
With as good outcomes as they may have had if they had gone to the larger?
I believe we did, yeah. I think we had great outcomes.
We had a question from somebody online about the situation with vaccinations now. We've now started to see a spike back up on COVID. There's a new strain that's out among us, and people are getting sick again, maybe not in the numbers or the level of hospitalizations or the level of deaths, but it's back to being an issue. Has the conversation, Mr. Serrano, in your community around vaccination changed here in year 3?
I think so. We saw a very high, vaccination as a percentage of the total population. I think the go around once the recommendation started getting a second or third booster, absolutely not. There's people that will not do that. If there is another surge, 6 months from now, a year from now, I don't know how many people will be immune.
But in the minds of most people now, pandemic's over.
Absolutely.
They're past that. They don't feel there's a need to go back there. Dr. Hogue, same?
Yes, I think the reality is COVID's here for a while. It's here probably to stay.
It's an endemic, not a pandemic.
Yeah,
Right.
yeah. And it's the severity is lessened, but we can't stress enough, you need to continue to get vaccinated and get boosted, and we're probably going to be doing that annually for a while. Yeah.
Anybody in the room? I'm happy to go to another question from online. I just want to give you all the opportunity since you made the trouble to come out. Here is a question back to the broadband issue, and that is, how does the current funding structure for healthcare hinder rural providers? In other words, what's different for you all versus hospitals in the big city or providers in the big city? And how can things be restructured for parity, equity, fairness? I'll let any of you, maybe Mr. Serrano, I'm going to put that on you first since you have CEO in your title. You probably haven't thought about that.
Access to specialty care is a huge issue. Unfortunately, to recruit a specialist to our community, there's just not enough volume that they'll see to get them there. So many of our primary care doctors have to do without or become the specialists themselves, especially when dealing with COVID. I think funding needs to be fixed. When Medicare pays you below cost, when Medicaid pays you below cost.
Well, and the reimbursement rates for Medicaid have been in Texas lower than they are in other places, have they not been? And that's a legislative decision.
In some instances, it's as much as 20 cents to the dollar below cost.
Right.
So not even above cost, below cost.
Right. So the question of the uninsured rate is compounded by the fact that for those doctors who are willing to take Medicaid patients, they're getting paid under market.
Absolutely.
Essentially for that same purpose. Same?
Yes,
Dr. Wuenschel?
definitely. I think, unfortunately, as a provider, I'm just going to take care of you no matter what, but just the way that insurance, Medicare, Medicaid, I mean, one thing that's just become more and more difficult is the amount of hoops we have to jump through to get the care that we want. There are some medications, there are, if you have to see physical therapy for 6 weeks before getting an MRI, but we don't have physical therapy available, or you have to see a neurologist before getting something.
So I'm about casting blame because I'm a jerk. I'm a journalist. Is it the insurance company's fault? Is it the federal government's fault? Is it the state government's fault? Who is putting these undue regulations or undue burdens on you, as you say, Dr. Wuenschel? So who's telling you have to do X before you can do Y, but then X is complicated, so Y is complicated? Is it the insurance companies?
The insurance companies, from my perspective.
Right. Dr. Hogue, do you have a perspective on the burdensome nature of things?
Yes, I think the golden age of medicine that has been communicated to me by the primary care doctors before me was after penicillin and before Medicare, because that really drastically changed the patient-physician relationship. All of a sudden, doctors can make a lot of money. They can game the system, changes incentives. So I blame everybody. I grew up in a town that the doctors owned the hospital. The relationship was between the patient and the doctor. When I started practicing, I could see 30, 35 patients a day, and then I was told that I had to get this thing called an EMR, which for an old guy like me was very cumbersome. It added more time documenting and less face-to-face time with the
EMR,
patient.
I'm guessing, stands for electronic
Electronic
medical
medical records, yes. Electronic health records, so
Patting myself on the back for
there you
figuring
go.
that out.
Sorry about that.
That's okay. No, it's good. It's good. It's
Yeah,
good.
so I think the electronic medical record does do good things. It does good things for insurance company. It does good things for quality tracking. Does it make care better? It gives you the opportunity to say you're doing better care with quality measures, but it has made medicine much less efficient. In the days
Got it.
where you could take care of, say 40 patients, you're
Right.
down to 20 to be effective.
I was thinking I'd have the opportunity to end this event on I blame everybody, but it turns out that there's one more question in the back, so go ahead.
We've mentioned a few times in here the inconsistency in communication, whether it be from the government or from the media or our stakeholders. But I did hear, it seemed like a couple times that personal stories seem to make the difference. So for the folks out here, who should we be listening to
That's a
when
very
we're
fair
getting our
question.
information?
Right, very fair question.
Yeah, unfortunately, I'm going to give you a personal anecdote. My wife's aunt lived in a rural community, Hispanic, overweight, diabetic. Who better to get a COVID vaccine? She was encouraged by her religious leaders and the community not to get vaccinated. So when she got COVID, it was very, very tough because we know that that was a life that was in jeopardy. She spent 5 weeks in the hospital before she succumbed to COVID. So for me personally, that's one case where it made a tremendous difference. We need to regain our trust in our patients. We need to listen to them, not dictate to them. We need to have physicians leading healthcare, not politicians. And I'll leave it at that.
Same.
100% I agree with it. To answer that question, I think your primary care physician is the best person to help you make some of these decisions. It's all about education and making an informed decision. That's what I look to when I see my physician. Your physicians are in the best place to tell you that. Real quick, I do want to touch on, in healthcare, the gatekeepers are no longer the physician. It used to be the physician. It's not the hospital. It's the insurance companies. Your insurance companies decide what level of care you're going to get, how long you're going to be in the facility, what kind of diagnostic tests you're going to have. And so I did want to
You
emphasize
feel
that.
like your hands are tied to some degree by that.
100%, yes.
Yeah, okay. Dr. Wuenschel, last word before we go.
I would definitely say your primary care physician, because that's what we're here for, and especially in those rural communities. I mean, since I've been there for 10 years, I know all those patients for 10 years. I know their mom, I know their sister, I know their brother, I know their great aunt. And so, I mean, I've known everything that's gone on with them for the last 10 years. And it has been those personal stories, the patient that comes in and is saying, I am not going to do that. And when you talk about it and talk about the changes and how things have affected people, they listen to you. But you have to have the time to be able to have those conversations and be in that community.
Well, I've really enjoyed this, and I think we have the great fortune to have had three amazing panelists join us. I want to thank Dr. Hogue, Mr. Serrano, and Dr. Wuenschel. Please give them a big hand. Thank them for their time with us today. Thanks to the president and everybody at Temple College for having us. We so much appreciate the opportunity to be back here. It was a great time to be on this campus again. Everybody in Temple who came out today, all of you especially, everybody watching online, thanks very much. If you enjoyed this conversation, I'll tell you that the Texas Tribune Festival, our annual conference Ideas Weekend, is September 22nd, 3rd, and 4th. There'll be 100 conversations over the course of a weekend in downtown Austin like this one, available for you to be part of on issues related to rural Texas, to healthcare, politics, policy, the whole thing, with a whole range of people you'll be interested in seeing. Festival.texastribune.org to get information about what we have planned, buy tickets and all that. If you're not a member of the Texas Tribune, our members make it possible for us to do this kind of work. You have QR codes on your table. If you're in the room, you're welcome to become a member, sign up to become a member. We'd love to have your support, texastribune.org/give. We will be back. We'll be continue to talk about this very, very important topic with you here and elsewhere. See you soon. Thanks again. Good to be with you.